I'd like to introduce our next speaker now. It's Dr. Nicole Sladden. She's a fellow of the Royal College of Pathologists of Australasia and has served on its state committee for several years and previously as a member of its trainees committee. Nicole's an associate clinical lecturer with the University of Adelaide and maintains an interest in teaching at both the undergraduate and specialty training levels. She's also a member of the Australasian Dermatopathology Society, the Australian Society of Cytology, and Doctors for the Environment Australia. Now, I first met Nicole as we were putting together an episode of This Pathological Life, episode 9, Transitional Crossroads, and it's a really interesting one because until recently, transgender people who have a gender identity or gender expression that differs from their sex assigned at birth have too often fallen into the too hard category when dealing with their health, disease, illness. And there are many reasons for this. And in this episode, we explore how to resolve that. We do it with Nicole, Travis, and Dr. Devika Thomas. Many challenges that pathology organisations like ClinPath face in order to best serve their patients. And putting that episode together was one that made us pay close attention to just the way our language obfuscates this topic. But today, Nicole's presentation will cover a selection of biopsy site and type, when and how to submit a second specimen for immunofluorescence, and which pieces of clinical information are of most use to the reporting pathologist. Nicole, over to you. Thank you.
Thank you, Steve. That was masterful pronunciation of unfamiliar words, as always. While I'm getting this ready, can I just encourage that stretching session was really great from Taylor, and I believe in stretching. I do stretches of one form or other after every tray of slides. The tray down and do as my physio has told me to do and actually do my exercises. So if anybody wants to do their stretches while I'm talking, please do. I won't be offended at all. Now, forgive me because I was not here at the beginning of the day. I'm just going to click and make sure that I understand how this works. Very good. Okay, here we go. This is meant to be a very brief and distilled version of the inflammatory skin biopsy. So I start all of my presentations with this comic by Gary Larson because I think it beautifully illustrates the relationship between pathologist, clinician and patient. A lot of the time when we receive a specimen, I think this is what we do. You know, patient presents with a skin tumour, you think that looks like a basal cell carcinoma, cut it out, you send it to us and we say, yes, it is a basal cell carcinoma and it's all gone. Easy, straightforward. Rashes obviously are a different clinical setting and a different challenge. So the point of this particular picture is really to show when we look down the microscope, if I was that person sitting on top of the microscope, all I would see is brown hair. If I can't see the rest of the patient, and I know that sounds obvious, but I think it's worth belabouring the point because you're the person who can see the entire patient and know whether the report that I write actually marries up with the clinical setting. So let's move on. When you're taking a biopsy in the clinical setting of rash, I think the main question that I certainly used to ask myself when I was in general practice, very briefly, was actually what am I meant to write on this request form? What's helpful? So if you take nothing away from this lecture, it's this slide. The most useful things for us to know are the distribution of the rash on the patient's body, the duration for which they've had it, and if you can try to describe it, that would be great, but if you lack the words because it's just an unusual looking rash, you know, give us a size. The biopsy site should be an obvious inclusion, but quite often we'll get a lovely history and we won't know where the biopsy's been taken from, so even if that's only on the specimen pot, the skin looks very vastly different when you're on the face compared with the arm, the trunk, the palms and soles, so it's really helpful to us to know where we are when we're looking down the microscope. Right, bonus points. If possible and if relevant, what's really helpful to know whether the patient has a past history of inflammatory diseases of the skin and if they've got an autoimmune history. So lupus is quite obvious, but rheumatoid arthritis, celiac disease, that spectrum of diseases quite often has cutaneous manifestations, and if we have the information we can narrow down our differential diagnosis, or we can just be really helpful and say, hey, it's not that. It's not dermatitis herpetiformis. It doesn't look like a lupus-associated disease, which hopefully is helpful for you. Relationship to sun exposure, this is the time of year where patients start presenting with rashes that are in the V distribution on the neck, on the face. And some of them, if you ask, will give you a history that, oh yeah, this happened last year or this happens most years in spring. Really helpful for us to know if you do elucidate that kind of history. Medications that they're taking, we appreciate some of your patients are on 30 medications, but there are some that are more likely to cause a cutaneous reaction. Those that have been started recently are often helpful to know, and anything that ends in MAB or AB. So if they're on an immunomodulator, a chemotherapeutic agent, something that's designed to interact with the inflammatory system to target a disease, they often present with cutaneous manifestations, and those are the ones we're quite interested in. And look, if they've had previous treatment, which usually is going to be some kind of topical therapy, let us know, because the appearance of the rash may be mollified. It may look different to us. If we know that they've recently had steroids, we can say, well, actually, it still looks like, for example, a spongiotic dermatitis. If we don't know they've been applying something to it, we may give you a wishy-washy report, which could have been more specific had we known that they were recently treated. All right. There's another approach. So quite often we get this, and I think it's quite useful. This is a list of inflammatory skin histories that I received a week ago. I include them because every single one of them included was from a general practitioner, and every single one of them was asking a question. It's really quite helpful if, for example, this history of hyperpigmentation, presumably it was multiple smaller lesions. Query pityriasis versicolor, it wasn't, but knowing that that's what was being seen clinically, a thing that looks a bit like pityriasis versicolor, still helps us to understand better what you're seeing. And that last one, isolated lesion on the forehead not responding to steroids, that was a follicular lymphoma, cutaneous follicular lymphoma. So not something that anybody would be expected to spot clinically, but it's nice to know there's this patch, it's not responding to the therapy I'm giving it. What do you think? Okay, now in your packs that you're taking home today, there are 2 journal articles. They're both from AFP or AJCP as it's now called. So I'm sure they're actually already in your offices on your shelves. But I thought they were both exceptionally useful. One of them I'll come to. One of them is probably a little bit more practical than the other, but both of them have really great tables in them and really good references, I thought, so I popped them in. So here is a list from the Harvey et al. Article, which is just a description of the words that we use associated with rashes. I know you would all have this in multiple formats, but I thought it was quite nice to have in an article to reach for should you need to. Right, immunofluorescence. We only need immunofluorescence really in one of 3 settings. If the patient's presenting with a blistering disorder, immunofluorescence is basically mandatory. We're not going to be able to sort out all of the differentials that we're considering without a second biopsy for immuno. The second setting is that group of patients who you think or know have lupus or other connective tissue diseases. And the less common one is the setting of vasculitis, where you think that Henoch-Schönlein purpura is worthy of consideration. The fourth setting, which is not one I would encourage that anyone needs to use exclusively, but there are 2 sets of patients who might present with itch plus rash, as opposed to I've got a rash and it's itchy, doc. I've got this generalised rash, generalised itch, and a rash, or I've got an itch and no rash at all. Elderly patients, like the older the better, but really anyone over the age of 60, they may be in the pre-bullous phase of bullous pemphigoid, and obviously dermatitis herpetiformis, again, if you think that's likely. Right, these are the two articles that are already in your take-home packs. As I said, I think the Stevenson and Roden's one is very approachable and straightforward. The second one is maybe a bit more esoteric, but has some really good pictures. This picture comes from the second of the articles. I know Craig has already talked to you about choosing biopsy techniques, so I won't belabour the point, but this is a really nice example of which layers of the skin are being sampled with a shave versus a punch biopsy versus an incisional biopsy. So in the setting of rash, the vast majority of the time, a 3mm punch biopsy that reaches to the subcutis, or in thick sites like the back or the trunk, the dermal subcutaneous junction will be useful for diagnosis the vast majority of the time. And the article actually demonstrates quite nicely which biopsy is most helpful for your clinical differentials, but I won't belabour that. The next question comes to selecting the age of the lesion. So if you have a patient with multiple lesions as part of their rash, in the vast majority of cases, just selecting a well-developed lesion is going to be diagnostic. There's a couple of exceptions. The first is in vasculitis. We don't want a really old established lesion because all we'll see is hemorrhage and necrosis, and you'll get a non-specific report. An established lesion is one that's been there for about a day, so your patient should be able to point to it and say, well, this is the area that came up in the last 24 hours. That's what we want to see. And early lesions, in the setting of blister and itch, we'd like a nice early lesion. The least helpful thing to biopsy is an area that's already been scratched and has a scab on it. Because we simply can't, when we look at that down the microscope, we can't differentiate what are the changes associated with the excoriation and what are really associated with the primary dermatitis that's driving the itch. Citing the biopsy, again, this is demonstrating that even if you're looking at it, particularly if you're looking at a blistering disorder, we want to get as much blister in as possible while still including a really small amount of normal skin, and that's great for us to compare down the microscope. And as I've already said, but I'll say it again because it really matters, avoid biopsying any lesion that's already excoriated. It will result in a non-specific report. Selecting a site for immunofluorescence in that group that we already discussed. How terrible. Sorry about that. Discussed. Okay, for a blistering disease, we don't actually want to see the blister at all if we can avoid it. We want to see the skin immediately adjacent to a recently developing blister, because that's going to be where the process is evolving. It allows us to assess the site at which antibodies or antibody-antigen complexes are being deposited, and it means that the tissue is still viable. Quite often, if we sample an older lesion with a blister, the roof of the blister, which is epidermis mostly, is already necrotic, and again, it just becomes a non-specific report for you, which is really frustrating. In the setting of lupus and connective tissue disease, easy, just pick a really well-developed lesion and biopsy it. And again, in a vasculitis, we want a lesion that's developed within the last day or so. Okay, this table comes from Roden's et al., and it's lovely because it marries up the appearance of the rash with the site that you want to biopsy. Really helpful. And actually, that was all I had to say with regards inflammatory biopsies. Now, I've got 3 slides talking about alopecia. Alopecia, I know, and so I can see a lot of people are taking photographs. Please, feel free to, but this is in your take-home pack so that you don't have to feel the need to document it all on the fly. Alopecia. I appreciate alopecia is a clinical setting that would usually be referred for dermatological assessment, but sometimes patients can't travel and sometimes patients can't afford dermatologists, and so you may occasionally want to take a biopsy for alopecia. which is why I've included the last couple of slides. This particular article is not in your take-home pack because it's just the one from which I've taken the images, and I wanted to give credit where credit is due. In the setting of alopecia, we divide those, and I'm sure you already know this, into scarring and non-scarring, or inflammatory and clinically not inflamed skin biopsies. The take-home message, please, for alopecia biopsies is 4 millimetres. Anything less than a 4 millimetre biopsy will not be adequate for a formal diagnosis. The reason for that is, and I will go to the next slide, the reason for that is that we process these biopsies very differently to a normal punch. So a punch biopsy taken for alopecia will be bisected in the transverse plane instead of in the longitudinal plane, and presented, as you can see, at the bottom left of screen. And this allows us to assess the follicular units. A follicular unit is a cluster of 2 or 3 hair follicles, sebaceous glands, the erector pili muscle, and the surrounding supportive stroma. We need to be able to, we use this to assess the maturity of the hair follicles, the level at which inflammation is occurring, and which phase of the hair cycle they're in, so anagen, catagen, telogen, all of which we use to come to a diagnosis of which type of alopecia has been biopsied. So if we just go back a slide, as I said, 4 millimetres is the most important message. The second message would be we really need to see subcutaneous tissue, and that's because the bulbs of the hair sit within the subcutis and quite deeply so in the scalp. So it's not it can feel like quite an aggressive biopsy, I suspect, to take of someone's scalp when they're already presenting for a cosmetically sensitive issue. But without a deep biopsy, you can't see the root of the hair, and without that, again, there are several inflammatory processes that we won't be able to exclude or include. And then the third message would be, ideally, we'd like to have 2 biopsies. Some patients simply won't permit that, and that's understandable. But if you can send 2, that would be great. The only real decision that has to be made is this patient presenting with an inflammatory or scarring process or not? So the patient down the bottom clearly is presenting with a non-inflammatory process, and in that setting, we just need a biopsy from the most affected area. The inflammatory and scarring ones can be more challenging because the tendency is to think, well, I'll sample the worst affected area and that will be that will be representative. Quite often what we see is the end phase of the process. So there's scar tissue, there's a bit of inflammation, and you would get a report back that said, this is a scarring alopecia, I can't tell you anymore. What's most helpful is to have an area of active inflammation, so redness, bogginess, and so on, where you can see some hair has been lost, but not very much. And that's where the process is active, and that's where we're going to get the most diagnostic information from. So, moving on to back to this slide. All I'm trying to demonstrate is if you send us 2 biopsies, we will process them very differently. The one on the right is your conventional punch that you would be used to seeing in textbooks and so on, and the one on the left is our dedicated alopecia assessment. There are rare clinical settings in which you might want to do direct immunofluorescence as well, in which case, and that's basically if you think lupus is within the differential for the hair loss. In that case, instead of sticking one of the biopsies into formalin, pop it in Michelle's medium and send it in like that. Or if you don't have Michelle's medium on hand, normal saline is also adequate. But really, we're getting into nuance that I think is probably a little bit unapproachable, and really just 2 4 millimetre biopsies is the most helpful. Okay, last slide of mine. Here we are, back to the beginning. Usually I remember to remove the word mammoth and put in the word, dog or cat or something like that. If you get a biopsy report from us and you think this is just completely out of keeping with what I was seeing clinically, whether it's a rash or whether it's, a melanocytic lesion, please don't hesitate to call. We like phone calls. We don't get them very often. Our direct numbers are on the every one of your reports. So, for biochemistry and so on, you'll get sent through to a generic number. But for For anatomical pathology reports, the number that's on the report is the phone that sits on the desk of the reporting pathologist. So you've got a very high chance of getting the person who's actually reported that biopsy. And we like extra correlation. We're happy to review slides if you think there's more information that we didn't have and would find useful. So